Afternoon. My name is Professor Arianna Di Florio. I lead the reproductive mental health program in Cardiff, and I'm a psychiatrist by training. With me today for this webinar, we have Chloe Apsey. Chloe, do you mind introducing yourself?
Hello. So I am a research assistant and PhD student working on our Premenstrual Dysphoric Disorder research project, also known as PreDDICT. And I'm going to sort of give a little bit of an introduction onto PMDD and some of the work we've been doing so far.
Fantastic, Chloe. Thank you. So the argument of the topic of today is PMDD, premenstrual dysphoric disorder, and differential diagnosis, especially with bipolar disorder. But the main reason to meet you all today in this webinar is that we really want to say thank you to the over 800 participants to our study on premenstrual dysphoric disorder that have taken part to our research thus far. And Chloe is going to share with you and with me some of the results of this survey that really you made possible. So the webinar is organized in 3 parts. First, we will launch today an animation. Is it called an animation, Chloe? With for premenstrual dysphoric disorder. We've been really passionate about outreaching and education, and so we've produced this short video that explains what PMDD is. The aim of this video is really to try to give at least really a glimpse, because it's just a few minutes long, an idea of what PMDD is, and this is to be shared with healthcare professionals and people that might have experience of PMDD either themselves or through families and friends. So we'll start with the video that again is part of a broader educational mission that we have in our group. Then Chloe will tell you about the results of our research that maybe some of you have already taken part, and we're really grateful. This webinar is possible today only because of you. And then I'll wrap up with a presentation on the differential diagnosis between premenstrual dysphoric disorder, bipolar disorder, mood disorder. If I'm angry, why am I angry, and those sorts of stuff. So Chloe, you're starting with the animation, right?
Yeah, that's right. Just get it. Share my screen if that's okay. Is that all on full screen? Should be.
It is perfect. Thank you.
Fantastic. So yeah, the animation is something we developed recently. We kind of wanted something that be short and summarize everything in a nice visual way that could hopefully be shared on social medias and things soon. So I believe I'm sure Ellie can clarify a bit better in the chat, but this should be online soon and able to be shared hopefully in the next few weeks. Fantastic.
So, what is premenstrual dysphoric disorder, or PMDD? Well, basically, it's a condition that affects the mood of about 5% of all people who have periods. Symptoms might start around a week or so before your period, and usually go away within a few days of menstrual bleeding. PMDD symptoms can include depression, anxiety, irritability, and anger. You might not be as interested in your usual activities, or experience changes in your appetite. You'll possibly have struggles with sleep or concentrating, and some suffer from physical symptoms such as tender breasts or a bloated stomach. Some of these symptoms are common with periods. However, people with PMDD can experience significant distress and interference prior to menstruation. Those with existing mental health conditions may also find their symptoms get a lot worse during their menstrual cycle. We call this premenstrual exacerbation, or PME. We still don't know the exact cause of PMDD. However, we do know it's associated with hormonal shifts in the menstrual cycle, and this happens between ovulation and around menstrual bleeding. To find out whether you have PMDD, consider speaking to your GP and tracking symptoms in a mood diary for at least 2 of your cycles. The support initially available to you may include medications, such as antidepressants or oral contraceptives, as well as talking therapies. If any of this sounds familiar to you, the National Centre for Mental Health is studying the condition to improve diagnosis, treatments, and support for those with PMDD. We are inviting those with experience of PMDD, or anyone living with severe PMS, to take part in an online study and potentially contribute a saliva sample or participate in a mood monitoring diary. Help us make a difference and visit ncmh.info/PreDDICT.
I'm gathering by the lack of frantic emails from Ellie that the audio was okay. The links at the end to the study we will also include in the chat, so you can have a look yourselves. So as the animation hopefully summarised quite well, what PMDD actually is and what we're talking about today. So PMDD is sort of, it's recognised by the DSM-5 anyways as a mood disorder. People with PMDD experience really severe mood symptoms such as irritability, low mood and anxiety the week before their period starts. The sort of unique thing about PMDD compared to other mood diagnoses is once their cycle starts, once the bleeding starts, these symptoms suddenly begin to subside, which is why when it comes to diagnosis, it can be a little bit tricky. And one thing that's commonly missed in research and is a sort of really important thing we like to highlight is that it requires 2 months of daily symptom ratings to see how these symptoms sort of fluctuate in relation to stages of the menstrual cycle. Yeah, so hopefully that kind of sums everything up. So our aim with PreDDICT, so PreDDICT stands for Premenstrual Dysphoric Disorders, Indicators, Causes and Triggers. It's a online survey that we have up at the moment. And our aim for this is to improve the understanding of how genetic environmental factors can help us identify individuals at risk. And yeah, our long-term goal is to improve the current approaches to diagnosis, prevention, treatment and support for individuals experiencing PMDD. Our sort of like individual aims also include trying to help destigmatize the topic of mental disorders related to female reproduction, which is why we've developed things such as the animation, and we're doing public involvement events like this, and hopefully getting to speak to people with lived experience, which we have been doing so far. Is this on presenter mode? Like, can you see my notes, Arianna, or is it full screen?
It's perfect, Chloe.
Okay,
absolutely perfect.
Brilliant. So what taking part in our survey, our study involves, so like I mentioned, we have our online survey. Should take about 20 to 25 minutes to complete, and we ask everybody, like the survey is open to anybody who has ever experienced symptoms of PMDD or severe PMS, whether they've maybe gone through treatment and no longer experienced them, or gone through menopause, or even are sort of at that really early stage of like, I think this might be explaining what I'm experiencing, but I haven't gone to the doctors yet. So we want it open to everybody, and we want as many perspectives from different people as possible. From there, we ask a subset of participants to complete a mood diary. So this is 2 months of daily symptom ratings. And in addition to that, or alternatively, people may be invited to provide a genetic sample in the form of a spit kit. So we post them out. You spit in a tube and you post it back to our lab, and yeah, we can process it from there, but it is kept anonymized. So where we are so far, so it's been about a year and a bit since PreDDICT was launched. We are at 838 participants, which is really exciting. We have 112 genetic samples, and unfortunately only 58 mood diaries, but that's kind of a result of some technical issues that we've been working on to resolve, and I kind of talk about that at the end of this presentation. So when we look at our preliminary data at the moment, you can see, so we have 284 people out of the 800 that have a PMDD diagnosis with a mood diary. So I'm sort of looking at that subset today. So we ask in the survey, what is your main lifetime diagnosis? So within that group, you can see the sort of diagnosis here that people list. Sorry, 1 second. So I will sort of clarify this further at the end, but we can't say entirely if these diagnoses listed here are a result of misdiagnoses or coexisting or comorbid diagnoses. But you can see here that a lot of people with PMDD list depression and anxiety disorders, which kind of seems quite expected when you consider the overlap between the symptoms. Also, yeah, so generalized anxiety disorder, and bipolar, which is what we're going to be sort of discussing in more detail today. So yeah, this slide sort of looks at the question, what are the diagnoses you've had in your lifetime? So you can see that quite a few people list more than one diagnosis in addition to their main, with some even listing over 10 diagnoses, which kind of suggests that a lot of them are going through a real process of misdiagnosis, getting lots of different comments from different doctors and taking a little bit of a while to get to actually it being associated with their cycle. Similar to the last slide, you can see sort of depression is one of our more commonly reported additional diagnoses. Again, this could be for a wealth of reasons that we can't fully speculate without greater detail. So, for example, similarities of symptoms between PMDD and depression. Alternatively, the impact of PMDD on a person's life is considerable. So when we've spoken to people with lived experience of PMDD, they explain that although their symptoms are kind of diagnostically at least limited to the week before their cycle, they tend to feel like they spend the next 3 weeks picking up the pieces. And as you can imagine, this is likely to take a toll. So this may be why we're sort of seeing this this common, like depression commonly listed. Alternatively, again, PMDD is a newly recognised diagnosis. It's not been, it got added to the DSM-5 back in 2019, and there's a lot of argument whether it falls under a mood diagnosis and therefore treated by a psychiatrist, or a gynecological condition due to it being related to the menstrual cycle. So this could be why depression is sort of more commonly given or suggested as the first port of call, because it's more widely known. Again, you can see here that there's quite a few people who've listed ADHD. This is something that's been really discussed a lot in the literature at the moment. It's not something we've focused on quite yet, but if it's something you're interested in looking into, there's definitely research out there. Again, I just want to highlight it's important to understand that relationships do not necessarily indicate causation, so we can't draw too much from that. But yeah, so our main focus today, however, is to look at bipolar, which I'm going to look at in more detail now. So the reason why, which Arianna will explain later in a bit more detail, that we're interested in bipolar in relation to PMDD is because both disorders are cyclical in nature. So there's to put it simply, there's times when symptoms are on and off, so it fluctuates. You can see in our group, in our PreDDICT PMDD cohort, that bipolar is actually reported less or sort of around the same as bipolar in females in the general population. So it's not increased anyway. And you can see here as well that in our 2 bipolar groups, so people who've listed bipolar as their main diagnoses or as an additional, they've also mentioned several other diagnoses listed. So this could support the idea they've had a bit of a lengthy journey of misdiagnosis, or they're experiencing lots of coexisting symptoms from different disorders, or even a bit of both. So this slide, this graph sort of summarizes the types of like the categories of disorders that the PreDDICT cohort that haven't listed bipolar and the PreDDICT cohort who did list bipolar are experiencing. Again, depression is consistently identified, but I think what's more interesting here is to see there's a lot more reports of alcohol and drug problems, and also issues related to eating in those who've reported PMDD and bipolar than those who reported PMDD alone. So this kind of leans more likely into the result of sort of comorbidity rather than misdiagnosis. So in other words, people with coexisting PMDD and bipolar, or reported coexisting PMDD and bipolar, may be more susceptible to issues surrounding substance abuse or eating disorders. So when I talk about comorbidity and diagnosis in relation to these slides, it's a bit of a complex thing to try and explain what these patterns actually mean. So from preliminary data such as this, we can't say too much, but as our data set grows and more people take part, we can consider more variables and hopefully better understand these interactions and hopefully distinguish between what falls under the category of comorbidity and what is actually reflecting sort of the quite harrowing process that many people with PMDD actually go through to get a diagnosis. So yeah, comorbidity by definition refers to the simultaneous presence of two or more disorders in one person, but there's also other factors to consider. So direct causation, is one causing the other, or is there similar risk factors that is why these two disorders are simultaneously appearing? And yeah, so there's more nuance that kind of goes into that. In terms of misdiagnosis, it's really quite common in people with PMDD. So IAPMD, which is a charity called it's the International Association of Premenstrual Disorders, they did a survey and they found that the average person with PMDD waits around 12 years to actually receive an accurate diagnosis, and have to go through 6 different medical providers in order to receive them. So it is definitely a lack of education, lack of knowledge, and just, yeah, there's a bit of a process both on the side of medical professionals and academia to try and get it so that this isn't the case. So yeah, it is quite likely that our data so far is just sort of illustrating that many people have gone through many different stages to receive an accurate diagnosis of PMDD. So what are our objectives for 2024 and moving forward with this data in this project? So recruitment continues. We need as many people to take part as possible. Our goal is to reach up to 1,000 genetic samples and hopefully be the largest genetic data set of people with PMDD in the UK. We want to overcome some of the limitations we've experienced so far. So I sort of briefly touched upon the issues with our mood diaries. It unfortunately wasn't working as well as we needed it to, especially when you're getting someone to complete it every single day. So we've been working with the computer science team at Cardiff to hopefully develop an app, which is going to make this a lot easier for both us and for participants to take part. And hopefully that'll be ready soon. In terms of analysis, so yeah, today I've discussed our initial observations, but as the project grows, we're going to keep looking into this deeper and hopefully getting some better answers for you guys about what these patterns actually mean. And lastly, collaborations. So we've worked quite a lot with people with lived experience, and we've used their insights to kind of guide our research, and we've tried to evolve based on the information that they have given us. And this is something we're very much going to continue doing, and sort of adopting the suggestions of our stakeholders. And we also have some new exciting research collaborations lined up, so we'll hopefully be talking about them in the near future. I'm sure there'll be a blog about it on the NCMH website once it's all been sorted. But yeah, it should give us some exciting new data and some more insights on how PMDD is affecting people in the UK and across the world. But thank you. I think back to you, Arianna, if that's okay.
Thank you, Chloe. I was busy trying to answer questions. I'll continue later. And if I forgot anything, please let me know and we'll go from there. I'm not the most tech-savvy person. I know that now I'm going to expand the screen. Is it okay? Can you see this? Chloe? You're my reference here. Is it visible?
Yeah, we could just see your thank you slide.
Okay, excellent. Yes, I think it's a really big thank you. Thank you to all participants to our PreDDICT study, but also to people with lived experience that help us shape the study in the first place, and also with the animation. We had a lot of feedback from them, especially the International Association of Premenstrual Disorders. So big thank to all of you. That is really the key message today. I'm going to talk about a specific clinical challenge, which is the difference between bipolar disorder and PMDD. This is something that I'm really passionate about. I find it so interesting, and it goes way beyond these two disorders. I think it's really an interesting and challenging topic. Chloe has shown you the rates that are not particularly different of comorbid. If you start with a premenstrual dysphoric disorder diagnosis, your rate of bipolar disorder is similar to those of the general population. On the other side, here we'll take more a bipolar angle and see how many women with bipolar disorder actually report PMDD symptoms and what's the difference between the two. In particular, we will focus on 3 questions. What is bipolar disorder, how it's managed, and what are the similarities and the differences between a bipolar and PMDD, and can you tell them apart, and can you have them both? This is usually a presentation I give in an hour. Now I have about 20 minutes. So I'll still we'll go through all the slides, but the aim here is to get you as much information as possible, and also you can then go back and see, read the slides in detail, or search the literature references I put here. So it'll be a bit quick, but you'll have, I think, enough material to I hope, bring something home from this. So starting from what's bipolar disorder and how it's managed. And we had a couple of Q&A questions on this thing, on names, diagnosis, and we always need to remember that the way we communicate between us, even this name of PMDD comes with from manuals. One is the International Statistical Classification of Diseases, and the other is the American Psychiatric Association DSM system. And these are categorical. So either you're happy or you're sad. You either have something or you don't. And they are symptoms-based. So it's like really a ticking boxing exercise. So really they're not really holistic in their approach. They don't consider the individual with all, like the aspects we all have. It's really difficult to make something generalizable from 8 billion of individuals, for 8 billion of individuals. So it's quite difficult, but this is the way it works. You either have something or not. And there are boxes you need to tick. And for bipolar, there are 2 approaches, and this shows you the difference and limits of these manuals. On the right here, you have the very cold, precise, specific definition of the manuals. And on the left, I put a description that K. Rifle Jamison gives of bipolar disorder. And if you are interested in learning about bipolar disorder from a lived experience perspective, this is really a great book, An Unquiet Mind, in which she talks about, the toll of a manic episode on, like ruined marriage, friendship gone, or drained, like bills to pay, and then depressive episodes, like I think is a much more relatable, if you want, much more empathic description of the issue. But for manuals and for today, the core feature of bipolar is a distinct period of abnormally and persistently elevating, expansive, and irritable mood, God-directed behaviors, or energy. Energy is new, and I think it's really important. And I think energy is a very important criteria, periods of really high energy. And when it's abnormally here. So, like it needs to be really high. And for many people with bipolar disorder, energy, mood, and behaviors are so high that they require hospital admission. So it's a very severe condition. And then there are some additional criteria that I've just listed here. We're not going through them, but just to tell that there is this core mania that's got some symptoms like grandiosity, decreased need for sleep. So people might, like clean the house at 3 a.m. because they're full of energy, and that doesn't feel particularly tiring for them. And, you might have racing thoughts, and we will have actually another webinar on hypersexuality in bipolar disorder and all the issues and the consequences related to, sexual behavior that can be risky and lead to risky activities. Again, there are some educational videos, and if you check out these videos, they'll show you interview with patients with mania. And this is to say, you need to see, and if you see it, you learn to recognize it. It's a very dramatic psychiatric condition, mania itself. It's episodic, so it's not that people are always spend their life in mania. And as Chloe said, both bipolar and PMDD are episodic, usually conditions, so it's not that you're always unwell, and that makes it also quite tricky for doctors. And this is, for example, a pattern of mood. You can see the symptoms of depression and mania. They can alternate. Sometimes you have both, sometimes you have only one, sometimes you're fine. So there is a combination of mood symptoms, but the core, again, is mania or hypomania, so high mood. Why are we talking about this in relation to PMDD? And again, this is a busy slide, but the take-home message here is because the treatment is really, really different. And while antidepressants are a first-line treatment for PMDD, they actually can be very harmful for bipolar disorder, even for bipolar depression. If antidepressants are ever prescribed in bipolar, they should be prescribed with a mood stabilizer. And as you can see here, this is the treatment for mania. As you can see, there is no antidepressant here. And if we go to next slide, the treatments for bipolar depression, you can see that antidepressants start to be here as a second-line treatment, but always as an in combination with something else, really the risk of switch to hypomania and mania is there. So bipolar is a mood disorder characterized by high mood or mania. It's cyclical or recurrent. It does have, sometimes it comes with irritability and depression. And the first line treatments are mood stabilizer. They are not antidepressant. Antidepressant can actually have negative impact. So it's good to really tell one from the other here. So what is similar, what is different between bipolar and PMDD? Again, very busy slide that's here, so you know the DSM definition and criteria for PMDD. Again, categorical, very restrictive. It's trying to reducing a personal experience of, a painful condition to something that can allow doctors all over the world to talk about it in a way that, we can tell people share these characteristics. And as you can see, there are symptoms that are very similar to those of bipolar disorder, which is the marked affective liability, irritability. Here we have even anger, interpersonal conflict, which can also be a consequence of bipolar disorder. We can have depressed mood with all the associated feelings of hopelessness, self-deprecating thoughts, anxiety, which is quite common in mood disorders. And as I was saying in the Q&A, PMDD is considered a mood disorder and is in DSM under the rubric of depressive disorders. So, there is this mood component, which is shared with bipolar, but bipolar has got also this clear-cut manic or hypomanic episodes. So we've got irritability is a very important shared characteristics. And I want to talk a little bit about this because I think it's increasing, and very often you get the question, I'm irritable, is that normal? And I think, defining irritability is itself challenging. And there are arguments that say, it's more common in females, but is it? And this leads me to a social, if you want, approach and point of view to these issues of anger, irritability in women, and whether they are normal or not whatever normal means here, whether they are pathological or not, whether they need to be addressed or not. And women around the world are really under tremendous pressures, and the trauma is really, really widespread. And here are some numbers about and some statistics that are really sad about intimate partner violence, about cyber harassment, even women in parliament, which you will think not exactly as victims in general. Okay, 82% of women in parliament across 5 regions reporting having experienced some form of psychological violence while serving their terms. So the numbers are high. We don't need to think about the worst scenarios of physical or sexual violence, but there are many, many forms of violence that women across the world are victims every day. In the UK, these are, again, some statistics, and on especially young women, you can see, are really a high-risk group of self-harm, and the risk is increasing, and the gap between young men and young women is increasing. And I think there is a lot to say about this, and also the most dreaded outcome, which is suicide in young women, is steadily increasing according to ONS statistics. So, there is a lot going on behind the scenes of the symptoms that people express and that we can observe, actually. Another element when we talk about aggression, anger, and irritability is alcohol. This is alcohol specific death rates in the UK, and as you can see, they are on the rise as well. Also for women, we tend to have more severe alcohol use in women than in the past. This is a slide for you, just in case you want to know about this. What is an alcohol unit and how much, a pint of beer or something contains, and the limits. I think that is interesting. It's surprising in reality how much we drink. At least I've tried to calculate it myself. I would not consider myself an alcohol abuser, but it's quite easy to go beyond the weekly limit, which is considered safe. And now there is an increase in literature that actually even what we consider safe is not that safe. And for women, I think alcohol is a particularly interesting compound because it has interactions with hormones. And so, I think for women, drinking alcohol, it's not, the consequence that you imagine for men, but on top of that, there are also hormonal considerations to make. Another important overlap between bipolar and PMDD is mood instability. And again, what is mood instability? We can spend here ages trying to define this. This is a systematic review here. If you're interested, if you're more, on the academic side, that can be a good review. And what I want to stress here is that there is a third differential diagnosis we should always be considering, which is what once was called borderline personality disorder. Now it's called EUPD. It's very similar concept, and for we should have an entire conversation and day on this. So why this diagnosis is so stigmatized? Because there is absolutely no reason to stigmatize this condition. It's a condition actually that can be addressed and should be addressed instead of denied. And again, mood instability, it's very common in women. It seems to be more common in women than men, with a peak prevalence in young women especially. And it's, not only bipolar disorder and PMDD have these issues, but also, as I said, personality disorder, but also other conditions. It's as a feature of several psychiatric disorders. And again, it's not always, there is not always pathological. We always need to be sure, before addressing stuff, we need to be sure they're severe enough to be pathological. And we could, again, have an whole discussion on what is normality in psychiatry and what is pathology. Borderline personality disorder, emotional unstable personality disorder, is a very important differential diagnosis. I'm not going to dive into detail, but I strongly recommend this review. And a very important point again, because what we are saying today, it needs to be useful. Usefulness is what we want. usefulness for patients. And here, this is an important differential because, as I said, bipolar and PMDD have different treatments. You don't treat them the same way. And emotional unstable personality disorder / borderline personality disorder also not treated in a third way, which is different from the other two. So we need to be really careful here because medications usually for this personality disorder don't work. But over 40% of people with this condition are free of more psychotropic medication. Okay, so we need also to acknowledge this fact. The fact that medications don't work for this disorder it's also always taken as these people are hopeless. It's actually absolutely not the case. There are talking therapies that work really, really well. They are evidence-based, and I invite you to look at this picture here on the right to see the treatment groups, like how well these talking psychological therapies work for these people. And the most common one is dialectical behavioral therapy, DBT, but there are also other therapy treatments. Definitely treatments for borderline require way more, energy from the patients, way more commitment than taking a pill in the morning. But they have really great results. And I think I'm a strong believer of these treatments. Of course, they need to be provided and delivered by expert. It's not an easy condition to treat, but not being easy and being untreatable are two very, very different concepts. And we see a lot of comorbidity between PMDD and borderline as well, or exacerbation. So again, I think this is something really important. And if I could do anything to destigmatize the condition, I would do, because I think I really don't understand. It's harming anyone involved, the stigma behind this. There's nothing to be ashamed of. This is a disorder as any other. And these are two specific papers on borderline personality disorder and premenstrual exacerbation, which again is an important differential diagnosis of PMDD. Very important. So how is it similar, different from PMDD, and how can we tell bipolar disorder and PMDD apart? Well, mania is really, really key and is a distinct period, and especially in bipolar 1 is dramatic, really dramatic. While PMDD, the timing is very different. It's not a distinct random period. It occurs in the majority of the menstrual cycle, the final week before the onset of the menses, and it starts to improve within a few weeks after the onset of the menses. So if you have symptoms, not only in the final week before your period, but also at other time across the menstrual cycle, that is not PMDD. It's an exacerbation of something else, or is something else that is currently not well defined in DSM. That is very important. And for borderline or unstable personality disorder, it begins in early adulthood and is present in a variety of contexts. And again, it can exacerbate before your period, but it's usually always there. So the key here is really prospective monitoring of symptoms. So what we do, at least in our clinic, is to give a personalized one, menstrual diary, live charting. Really, you can choose pen and paper, electronic. And I think that is also therapeutic itself, because you start to get controls of your control of your mood and your symptoms. And again, I know there are apps that can, like in one question, they ask about daily mood. I don't think they are really helpful or work really well, because there are several elements that need to be considered. I've shown you there are pages and pages of symptoms. We didn't even go through because there were so many. So I think the more questions actually are rated on a daily basis, the better for this. Like you don't want, hundreds of questions, but definitely one is not enough to establish a mood monitoring system, in my opinion, especially when the differential diagnosis is so, so important. So can I have both quickly? Yes. However, PMDD, look at this criteria. It's a diagnosis that excludes other disorders. If there are other disorders, that it's called premenstrual exacerbation. It's not PMDD. PMDD needs to be pure. There are tricky situations. For example, when you have a bipolar spectrum disorder that's not well classified, plus PMDD, or you can have PMDD in people with a previous history of mania and depression, but now they are well and they only have PMDD. Or then you can have a circummenstrual exacerbation of bipolar disorder. So you always have your bipolar episodes, but they get worse before your periods. And there is very little research on this, and I think this is a very serious problem. So there's not much we can say about these conditions, but there are definitely some points I want to emphasize. These are really medical, purely medical points. Lithium valproate, especially valproate, is associated with menstrual abnormalities, and actually valproates should not be prescribed to women in reproductive, or people of reproductive age. So, you know, like these are quite notorious issues. Lithium concentrations vary across the menstrual cycle, so that might also impact the mood across the menstrual cycle of women on lithium. But that's not the case for valproate and lamotrigine. And there is a possible association between bipolar disorder and menstrual dysfunction and insulin resistance. We see PCOS, but again, that is related to medications as well. So there are some links that need absolutely to be explored further by research. Claire Dolman ran a survey, a women's survey with the charity Bipolar UK, and I invite you to check that out on Bipolar UK website. It's a very extensive survey. She also ran some webinars on this, and she asked, and you remember Chloe telling you that the prevalence of bipolar disorder in people with PMDD is not different from the general population. However, the prevalence of menstrual symptoms in bipolar disorder is quite high. And as you can see, the majority of people actually do report at least some symptoms across the menstrual cycle. So what can be done? Again, I think excluding medical comorbidity, be careful with coffee, alcohol, you know, cannabis, painkillers, you know, they do have side effects. Very important, I'll never get tired to say this, longitudinal perspective, daily monitoring of symptoms is so important. Be clear on the symptoms if you can. This, you know, this is something your doctors can help you to tell. Is this rage? What is this? And also, I think an in-depth personality assessment, that is really important. And I think that is something we tend to neglect. Mood monitoring, we've already spoken about this. And again, this deep personality assessment here, the last point, I think, is absolutely key. And I don't think it's done enough because it requires a lot of time. It requires hours. It requires to establish a relationship with a patient and, you know, like see, I think, those interactions. And there is also a lot of stigma and a lot of fear of having, you know, personality issues. But I think that those are really important factors in treatment resistance and other problems. So to conclude, antidepressant can trigger mania, so we'll need to be careful. Pharmacological treatment is not recommended for borderline personality disorder per se. Antipsychotic and mood stabilizer are currently not in PMDD treatment algorithms, and they can have significant side effects. They are quite heavy, you know, medications. There are case reports of home-based treatments causing mood symptoms of episodes in bipolar disorder, but we don't know much. And medical and affective psychosis are psychiatric emergencies, so don't take these conditions lightly. So I think these were the points I wanted to discuss with you today, and I want to thank all the team. This is a massive effort of many people, including our collaborators at Bipolar UK, Claire here, and the International Association of Premenstrual Disorders, especially Laura here in the UK. Thank you. So we have some questions now, right?
I've been answering a few of them in the chat, but I think there's a few that are probably more targeted to you, Arianna.
Okay, I'll start with the Q&A. If we don't manage in the next 15 minutes, I'll make sure we'll collect them, right, Ellie? Ellie, by the way, we didn't introduce Ellie. Ellie is the director here, is the person
Hello.
running the thing smoothly, right, Ellie?
Yeah.
We'll make sure that we answer all the questions somehow, right, Ellie?
Yeah, definitely. I've taken screenshots of a lot of the questions too.
Fantastic. So Emma, Emma is asking about ADHD and PMDD research. So Emma, I think most of research is ongoing. I was going to share with you a paper that has been published by I put it in as a reply to your question here. But again, I think we are in a stage in which research is more conducted. If you search the literature on this, it's more reviews, case reports, stuff rather than actually. Oh, I see that Chloe has already replied to you. Fantastic, excellent. So that is one of the papers on this. I think there are not many actually. Okay, Chloe has responded to all Q&A here. Okay, Debbie, we are here suggestions that clinicians can people see the Q&A? Or shall I read them out loud?
I think read them out loud. I think Ellie's just put in the chat some of the ones that we got emailed through before as well, which obviously I haven't answered.
Okay, so we're hearing suggestions of clinicians moving away from PMDD as a diagnosis instead of one element of PMS spectrum. Okay, that's potentially problematic, historical misconception, stereotype. I agree. I agree with Debbie that says, what's the difference between PMS? And I think we got also a question about PMS and PMDD, severe PMS. And I agree. And I think it's stigmatizing on the mental health component. And I think women have, and people, you know, like with PMDD, PMS, have been caught in the middle of a cultural, I don't want to say war, but I can't find a better term, between the gynecological perspective, which is a very, very, you know, like medical, very hormonal, you know, focus versus the more psychiatric one, which in my opinion is more holistic, you know, like it's more the dysphoria, more this element. So, you know, like you need to have mood symptoms for PMDD. PMS is not clear to me exactly how, you know, like it's never been codified like with a lot of rigor. So I think, yes, I agree with what you're saying. There are historical misconceptions and stereotypes about PMS, but there will be also on PMDD if the mentality of people is that. I had a conversation a while ago with Claire Dolman on whether postpartum psychosis and bipolar disorder, what's the relationship between the two, how we should call stuff. And I was like, it doesn't matter how you call them. The important thing is that the way you address, you treat, and you manage them. And actually, she was in deep disagreement with me. And now I can see the point, because as you say, Debbie, these diagnoses carry stigma with them. And I personally use PMDD when, you know, like it's codified. I know what it means. It's really, the criteria are really clear in DSM, and there are guidelines on how to treat it. The rest, I'm not sure what it is about. So, you know, I'm really pro evidence-based medicine, and I think PMDD helps me that way. But, you know, if people have stigma against women having issues, they'll have stigma even if you call him PMDD. That needs to be clear. Difficult women is always something, right? We should be called just difficult women in the first place. If a person has no other disorder and experiences PMDD symptoms around ovulation as well as the week before the period, is it PMDD or something else? Well, again, this is a matter, as I said, the manuals, the diagnosis at the moment are quite constrictive. And there is an article, Anna, by a scientific paper on this by Tori Eisenlow-Moore in psychological medicine that shows the various patterns. And there are patterns that are not the classic PMDD, but how we address that and how we frame that is still not clear to the international community. So that is, you know, like we don't know basically, unfortunately, but there are people experiencing that, definitely. So there are some questions, I think, that are more on the subject, you know, more personal on their experience. So I'll try to make something that is more a general point from the question.
Arianna, I'm happy to read out some questions that people have submitted
Yes, please
previously.
do, Ellie. Please do,
Yeah.
please do. Yeah.
So someone has asked, is PMDD considered a neurodivergence?
Okay, so diversion is not a medical term, and usually it's considered an umbrella of conditions which are more on what was called once the neurodevelopmental spectrum. So like dyslexia, certain learning, difficulties, or ADHD, certain other symptoms. PMDD, it's usually not consider that, but again, PMDD, as I see it, is a diagnosis in a manual with certain characteristics, with a certain definition that I can agree with other professionals around the world. Neurodiversity doesn't have that very fixed definition in medical manual. You could have both, definitely. So that is the answer, I think.
Next question is, with the awareness of PMDD increasing, is it attracting more research funding?
I'm not sure about that. I would say yes, we'll need to see. Is it locally, is it more national, is it more international? It depends. We'll see. There are definitely more grants submitted on this. There is also a question of the quality that is coming out, right? Because no more funding doesn't necessarily mean better research and can actually create more confusion. Definitely is a good moment to investigate these disorders. I think there is definitely more awareness than in the past.
Next question is, in terms of treating PMDD, what are the best options as it's such a fluctuating and cyclical condition?
Oh, that's a very good question. So recently, the American College of Obstetricians and Gynecologists published their guidelines, which are quite similar to the British counterparts. And I think the best evidence, if you want to go in detail there, and I can tell you also what leaves me perplexed about those guidelines, but in general, the first line treatment with more robust evidence is and a class of antidepressants. And this class of antidepressants can be given in two ways, as you said, because it's cyclical. You can give it just for a few days a month, or you can give it continuously. There are studies showing that both methods can actually work. And it depends also on how you tolerate antidepressants. I find it very interesting that the short-term use works as well, because usually, like you're told in school that antidepressants require a bit of few weeks to show effectiveness. And then there is certain types of hormonal contraception with the objectives of suppressing ovulation. And I think this is a key point. The hormonal treatments of PMDD are aimed to suppress ovulation, because the way that is the mechanisms are understood here is that PMDD raises from hormonal changes that are consequent temporally to ovulation, okay? But is that the case? Really, I would say we don't know for sure. Like there are studies showing this, but it might be only in a subgroup of women, that might be not in all. There is a massive placebo effect, which, the number needed to treat, which is a statistic you should always look when you take a medication. And the higher the number needed to treat is, the more likely the placebo effect is. And I think for these treatments is quite high, so hormonal treatments have also this issue that, and also, I've read questions about people having symptoms after hormonal suppression, either surgical or chemical, and then with HRT. And if you have symptoms, what is then the problem, right? Cannot be ovulation. We know so little. And I think that needs absolutely to be explored. I always invite people to be really, really careful. And these are medications, but there is all, and I want to spend a minute on this, if you don't mind. It's an unsolicited thing, but I think it's really important. and I want to stress this, you know, there are people that absolutely need medications, and medications are vital for many of the conditions we're discussing today. I will never, especially for severe symptoms. Can you see my screen?
Yeah.
You know, medications are absolutely vital for many conditions, but talking therapy are also very important, and lifestyle is very important. And I wanted to show you this graph that comes from The Economist. It was a couple of weeks ago on the amount of antidepressants that are taken by British people, and apart from Iceland, is the highest in Europe, and it's increasing massively. If you see, is almost doubled in the past 10 years. So what is happening here? Why do we take so much antidepressants? And this is the second figure here. If you see, then you go and ask people how they're doing, you know, like in a more systematic medical way. And actually, the people in England, Wales, and Scotland are not that unwell. So I think in the UK, there is an abuse of pharmacological treatments. And in my clinical practice, I see that people would prefer a pill definitely to 1 year of talking therapy, well done, structured weekly, you know, and that is understandable. There are also financial constraints to this, but I think this is something we should reflect on when we think, shall I go for medications or not? And I always recommend this book. This book is a bit, you know, like if it's more for the academic-minded people, because there is an entire chapter on a German philosopher called Hegel that even I haven't read. But there are some really, really good chapters. It's a really short book on emotions and how we really struggle to understand what is pathological and what is not, especially with negative emotions. So I think in the treatment of any condition, we always need to balance the severity against, you know, like the side effects of drugs, and do we really need drugs in the first place?
I think, Arianna, I don't know if you can see them, but on the Q&A, there was a few other comments about antidepressants and things like that. Like, for example, about how cyclical SSRIs are used in PMDD, like, you know, when they take them during the luteal phase only.
Yeah, that would be, yes, that's an option, but another option is to take them continuously. Yeah. It can be done both ways.
They were asking about whether, like, how I don't know if there's a paper to do with how the side effects of coming off and on to antidepressants. Is there a paper you can think of?
So usually antidepressant, I think if the issue here is the withdrawal symptoms from antidepressants, that is a concern when you take them for quite a long time. And there is that concern. And I think, you know, like it's often underplayed. And this is why I always think, do you really want to take medications? Is there anything else can be done before? And that is a consequence, but there is no medication that is without side effects. And for that, the Royal College of Psychiatrists has got a very nice leaflet for patients on how to explain this issue of, you know, like stopping antidepressant. Definitely for the cyclical way, there doesn't seem to be that withdrawn effect because it's just 2 weeks. But, you know, like if you take them long term, that is definitely something to be considered. I don't think is spoken enough about, definitely.
Thank you. Yeah, that was it.
Anything else? I'm aware of time.
There was one.
I think we've got time for one more question.
Mm-hmm.
If you have time,
Arianna, that I think we've discussed privately, and it kind of relates to some of the data that I was talking about earlier, to do with trauma and PMDD. I think there was there somebody investigating that, or have I completely?
Yes, there is, but again, at the same time, there are people with PMDD that have experienced trauma and that needs to be addressed. There are people with PMDD and a comorbidity that have experienced trauma, and the trauma can be triggering of both condition, or could be in the, you know, causal, if you want, pathway of both condition, and needs to be addressed. I was having yesterday a discussion with a colleague of the fact that I'm afraid that now we're going the other way around, that when there is, again, I use this term, and I hope you understand what I mean, a difficult woman, we tend to say, oh, it's trauma, and just to get rid of her from the medical room, you know, like, I think this is something that should be addressed together with the other factors if it's present. Definitely can be present. I've shown you the numbers. I mean, the numbers are staggering. The presence of trauma in women is more common than we think, even in women without psychiatric disorders. But definitely if there is trauma and a psychiatric diagnosis, that needs to be addressed. And I think that can be a reason why treatments don't work.
Fantastic. There's one other question which I think I could probably answer really quickly.
Yeah.
Is a few people have mentioned about how their symptoms, like how do they know it's symptoms of PMDD or ADHD, or if their symptoms seem to be 2 weeks before their cycle. I think the main thing that I would suggest anyway is that if you go onto the IAPMD website, which I will link in the chat, they have these downloadable mood diaries, these 2-month mood diaries, and I think the best thing you can do in them situations is track. That's how you're going to be able to see if these are related to your cycle and stuff like that, and you know, answer them questions specifically. Yeah, because that's sort of the clearest way you're going to see them patterns emerging. I think Ellie's just put the one in the chat is that one, and IAPMD in general just have some really great resources on there that can hopefully answer your more specific individual questions. That sounded right, Arianna?
Yeah. So it's quite a very complex area. I feel extremely complex. And we need absolutely, Lorraine, I think, is making the point of the complexity. And yeah, I think an hour here is not. Also, we organize these webinars, I think, for an audience of any, you know, like people that take part in the study because they have lived experience, to people that are just curious, to more, you know, to researcher, healthcare professionals. So covering in an hour all the levels is difficult. But I think, to me, really the take-home message, the information we get from the outside needs to be weeded out a lot. There is a lot of information needs to be put into context, and I think the context is also psychosocial, and also that is very often absolutely forgotten about, the complexity of multiple diagnoses. I think the thing, hormones make women do things. I find them a bit the new version of hysteria. I don't know if you know hysteria. It was condition that women were diagnosed at the end of the 20th century and 19th century, and yeah, and all went on and on and on through the 20th century. And I think sometimes I wonder whether how many women are just dismissed, saying, oh, it's a mono, go. I find that also a bit of misogyny into that. Anything else? Ellie, you're keeping us on time. Whoa.
Yeah, I think that we've run out of time now, unfortunately.
Yeah. Have we got saved all the questions so we can answer?
Yes, I have taken screenshots of the questions, and I'll pop over the pre-submitted questions to you as well. Also that we've shared some links in the chat box to our website. We have a Padlet, which has links to anything that we've mentioned in the webinar today, which we will continue to upload. We've also got a survey if you wanted to leave us any feedback from today, and we will be sharing the recording of the webinar in the next few days.
Okay, and we're sure we have got both the Q&A and the messages, how are they called, the chats, so yeah, we can
got
both. Okay, fantastic, excellent. Thank you everybody, everyone to take part. Much appreciated. I hope this was useful to you. Bye.
Thank you. Bye.